Thank you again to everyone for joining us today for the viewing of Spark. I'm Christina Irving with Family Caregiver Alliance, and we're grateful to the Lewy Body Dementia Association to be able to partner on offering this film. FCA has supported caregivers for over 40 years, including many with Lewy body dementia. And so I hope this film and the discussion will resonate with many of you. Before I introduce our panel, if you have any questions, please feel free to enter them into the Q&A box on the right side of your screen. If you have your video as full screen, you'll need to exit by clicking the arrows in the bottom right-hand corner of the screen. The moderator for our conversation today is Robin Riddle. Robin is the CEO of the Brain Support Network, which began as a support group for caregivers of people with Lewy body, as well as a number of other conditions. And she's been a great partner with FCA in supporting caregivers for many years. She's joined by Dr. Bruce Miller from UCSF, and you saw Dr. Miller in the film. He is the director of the UCSF Memory and Aging Center and the co-director of the Global Brain Health Institute. And we're very grateful to have his expertise today. We also have Diane and Denise joining us to share their experience and expertise as family caregivers of someone with Lewy body dementia. Diane took care of her husband and Denise cared for her father, and both have used their experiences to support other caregivers. So thank you all again for joining us, and I'll turn this over to Robin.
Thank you very much, Christina. It's a delight to be here with all of you and to be sharing this wonderful film and our terrific panel. So let's start off with Dr. Miller. The terminology is just incredibly confusing here. We have Lewy body dementia, diffuse Lewy body disease, which was what was on the pathology report for Robin Williams. We have Parkinson's disease, dementia with Lewy bodies. Can you help demystify this?
Yeah, and I apologize for the terminology and wish I had a simple solution for it. So let me give you a slightly complicated answer, Robin, because I think this is really an important question for families. So this used to be Parkinson's disease. And we used to think of Parkinson's disease as a movement disorder that had no effect on behavior, mood, anxiety, or emotion. And over time, we learned that many people with Parkinson's disease don't actually present to the family, to the doctor, to society with a change in movement. Rather, they present with changes in things like visual hallucinations, delusions that they never experienced before, with profound disorders of sleep. And in fact, I would argue that almost all people with Parkinson's disease have a propensity to these problems. And although some may present with a pure movement disorder, these are really different parts of the elephant. The elephant is the bad protein that aggregates in the brain. It's called alpha-synuclein, and it causes Parkinson's disease. It causes Lewy body dementia, dementia with Lewy bodies. And I think they're just different ways that the same molecule can wreak havoc in the brain. And I think as we move toward therapies, what's going to be incredibly important is to recognize this, all the different forms with the one common molecule, which is alpha-synuclein. And I believe in all of our lifetimes that there will be a day when someone presents to the doctor with a sleep disorder or the psychiatric manifestations or the cognitive manifestations, we call this Parkinson's with dementia, that the treatments will be focused on the primary cause, which is this misfolded protein.
Thank you. One of the questions that one of the attendees asked is what percentage of people with Parkinson's disease go on to develop what we call Lewy body dementia?
Yeah, well, a really great study done in Norway suggested that at least a quarter of people with Parkinson's disease, if you look carefully, also show cognitive issues or behavioral issues early. So I think a lot of times the field has ignored this. They focus on the Parkinson's and they forget that is the severe anxiety, which is the same disease, that is so disabling to loved ones, to caregivers. So I would say a very high percentage of people with Parkinson's, it's not pure, it's not just a movement disorder. And I think we've learned about the spread of the bad protein. It doesn't start in the movement part of the brain. It starts in the part of the brain that's involved with regulating emotion, attention, sleep. So these are often there with the Parkinsonism. So very common.
Okay. Given that, it seems odd then that it was so hard for Robin Williams to ever receive a diagnosis of Lewy body dementia. And incredibly, he had all access to all these resources, different kinds of resources, and yet he was still unable to get a diagnosis. Why was it so hard for him to receive that diagnosis?
Here's what my belief is that in our society, we have tended to pocket into different categories, psychiatric symptoms, which when we do this, we often stop thinking about the brain, and neurologic symptoms where we know the symptoms come from the brain. But in the case of Lewy body, and I think Andrea Saraton did a great study here at UCSF that showed almost all of the people who had Parkinson's disease who eventually came in for deep brain stimulation, almost all of them had begun with a mood disorder or an anxiety disorder. And so I think realizing that the mood disorder and the anxiety disorder are not just late life psychological problems, adjustment disorders. This is a disease. This is the beginning of Lewy body disease. And I think until we realize this, we will misdiagnose people. And even more tragically, we will treat them inappropriately. And sadly, I think Robin got a lot of inappropriate treatments that didn't focus on the biology of his problem. It had a real chemical basis, a real biological basis, but people didn't really grapple with that.
Yeah. I'd like to turn now to one of our caregivers, and Diane. What was the process like for your husband getting diagnosed? Was it a challenge, or was it fairly straightforward?
It was definitely a challenge. We were living in Hawaii on one of the outer islands, and I noticed, first off, that we were not on the same page anymore. Things that I would tell him, he would say he hadn't heard before. And so when we had appointments, he didn't register that. And there were just so many things. He forgot where he was going. I'm not hearing myself, but he didn't know where he was going sometimes, and he didn't recognize friends that we knew he should know. Do you hear me? Because I don't.
You do.
So his doctor, a local island doctor, said there's nothing wrong with him. We can do a blood test and test for that. And so when a farm and garden owner called me to tell me Gary had just been there, picked up some things, and he was afraid Gary wouldn't make it home because he was driving by himself. And I called the doctor immediately. Doctor said, oh, yes, we will do a check on that. Bring him in first thing in the morning. We did that. Later that day, he said, there's nothing wrong. Blood test is totally normal. My friends were saying, what's wrong with Gary? He has no expression to his face whatsoever. It was like a mask. I'd try to take a photo and say, smile, Gary. And he'd say, I am smiling. finally, it was a urology friend who lives in San Francisco that we came back on a trip, and Charlie said, "What's wrong with Gary? Please, Charlie, help me if you can." And that's when we saw doctors in UCSF, and they told us, no, he doesn't have Parkinson's, which is what Charlie had thought. He probably has dementia with Lewy bodies.
Could you talk a little about Sorry, could you talk a little bit, Diane, about what your husband's response to the diagnosis was? Did he accept the diagnosis? Was he in denial about it?
He was very, very relieved when the neurologist told him, "You do not have Parkinson's." And then he just turned off. He was fine with that diagnosis. He can still drive. He can do whatever he wants to. He's not got Parkinson's. But doctor said, "You have either Lewy bodies or multiple system atrophy." And I had him write those down. And later on, I went to the web and researched both of those, and we were given some medication. If it's this, it'll help. And it was amazing how his expressions came back to his face, and he was able to show his emotions, and a lot of things were working again after that medication. And I was relieved, but then things got worse later on.
There are always new
But at
symptoms.
least we knew what the diagnosis was probably, even though you can't tell for sure until an autopsy.
Right. Denise, how about for you? What did it mean for your family to receive a diagnosis, and was your dad accepting of it?
Well, my dad was diagnosed with Parkinson's disease. He was resistant to get the diagnosis or go in and ask because he was walking like Tim Conway in that when he did The Old Man with the shuffling feet and didn't go anywhere. And we encouraged him to go find out if this was just old age or if it was something else. But he had a trip planned for I think it was the christening of his first grandchild in the East Coast. He didn't want to visit anyone, and the doctors telling him he couldn't fly. So when he came back, we went to the Parkinson's Institute because then he confessed that his doctor had suggested that he should see a neurologist. And when we got the diagnosis and the prescription for the Cinemet, the first pill turned back the clock by 2 years. It was amazing. And so then he was very pleased because he wasn't, struggling any longer. And he was effectively treated for Parkinson's for 5 or 6 years before he had his first hallucination. And it was, I think we learned a lot through the Parkinson's phase, that the more you know, the more you can help yourself. And so then when the diagnosis changed, we just kept pursuing information about Lewy body. And at the time, it was probably 15 years ago, and neurologists were still expanding their understanding of Lewy body. So there was nothing on the web. I think there was one book out.
What about the process for meeting with physicians? Did you always have another family member present beside your father? How did you get information?
Yeah, Dad had an excellent neurologist in Corvallis, Oregon. She actually knew what Lewy body was when we suggested to look into this, and she was great. So with myself until my mom needed a hip replacement, and they moved in with us to have the surgery here at Stanford. So they lived with us for the better part of 2 years. And I went to the neurology appointments with him at Palo Alto Medical Foundation. And then I started learning a lot more about what he needed and adding another dose of Cinemet or a time release at bedtime and some of the details. But when they went back to Oregon, I wasn't involved anymore. So he was back with just himself. And after some time, we had to move them to California so that they would get more support.
Dr. Miller, we're having a lot of questions here about treatment, and both Denise and Diane mentioned some dopaminergic therapy that's very common for Parkinson's disease. Could you speak to the treatments for Lewy body dementia and also the conundrum associated with treating psychiatric symptoms versus treating movement symptoms?
It's a great question. And I think there is some hope. I'm really delighted to hear these two stories of some effective treatment early on. So there's no doubt that diagnosing this is really the first step for a family. And it often is a huge relief to understand what this is. So I think of three neurotransmitters: dopamine, and you heard Denise talk about, and Diane, about how profoundly the dopamine type compounds can help movement. The other thing that happens is this disease affects what we call the brainstem core. So we have neurotransmitters that go from the brainstem up to the cortex. And there are three different types. There's the dopamine, and that's very much involved with movement and some attention. Then there's serotonin. And I think the serotonin deficiency is one of the reasons that we see so much depression as an early feature of this, and sometimes unalleviated anxiety in someone who was never anxious. So I think of that aspect of the disease as a separate but treatable component. Then the third part is attention. And sometimes there's a profound loss in the drug acetylcholine. And so if we can boost acetylcholine, I think we can diminish the hallucinations, the trouble with attention, the tendency toward becoming delirious. So we know Lewy body people, because they're so deficient in acetylcholine, that if a little thing happens, like a urinary tract infection or a post-operative, this cholinergic deficiency leads to a profound delirious state, completely confused, alterations in sleep and wake. And I treat often all three at different stages of the illness. And I think we can usually make a pretty significant impact on caregivers and the patients themselves' lives by thinking about these different treatable pieces. And then, of course, there's the sleep. And I think that also has its own unique therapy. So I think early on, before there is a profound dementia, I think we can do a lot to help people. And I think keeping that in, I mean, that's such an important thing that all of you do, in your advocacy work, is really tell families, don't accept that this is untreatable. It's uncurable at the moment, but it is very treatable.
And since it is uncurable, what is the value, Dr. Miller, in getting a diagnosis?
Yeah, I mean, I think the value is, I think, helping the people understand why, what. I mean, I think most of us deal very poorly with mystery in our own lives. And I think having certainty about what happened is important. I think because we have our own unique therapies for Lewy body, that it's important to diagnose this properly. And then, and it's always important for me to explain to families, I know this person, is different and they never were anxious, but it's because there's a chemical change. And, so I think getting a better understanding of the architecture of this is really important. And then I'm an optimist here. I really believe that we are just on the verge of disease modifying therapies for Alzheimer's, for frontotemporal dementia, and for Parkinson's. And so I think that suddenly we have huge support through various foundations, through the National Institute of Health, and we understand so much more. I think we're really going to cure these diseases. So I think this is why I think diagnosis is going to be so key.
I think another reason for the diagnosis being important is my husband had to have knee surgery halfway through his illness. And the type of medications used in surgeries can have a big part on what the brain does. During surgery, they did a saddle block on him rather than the normal anesthesia. But after surgery, when he went into a rehab facility, he was given the totally wrong kind of medication. And that doctor didn't know that they couldn't give that medication to him. And he was totally anxious, was having the most horrible hallucinations could possibly imagine. It's just frantic.
And that's
go ahead, Dr. Miller.
no, I mean, it's such a great point. And that's preventable. That's avoidable.
It would have been, yes.
Denise, I'd like to ask you, we've vaguely touched on some of the behavioral challenges associated, some of the psychiatric symptoms, as Dr. Miller said. What kind of psychiatric or behavioral issues did your father exhibit during his course, and what was challenging for you?
Well, he definitely had REM sleep behavior disorder for probably at least a decade, probably longer, prior to his movement challenges, to the point where he threw himself out of the bed into the corner of the room behind the nightstand one evening when I was staying with my parents. And we just assumed, because he was in World War II, that these were sort of a PTSD, nightmares about the war kind of a thing. And then you learn more and find out, oh, if you have this moving in your sleep, talking in your sleep, nightly, really very common experience, you're much more likely to develop Parkinson's and Lewy body dementia. So that continued. I don't know how mom stayed sleeping with him in a double-sized bed for as long as she did, but I think that her sleep contributed to her earlier. Perhaps she would always have had Alzheimer's, but I think it would onset earlier than it might have because of her lack of sleep. Of course, the hallucinations, the first time that happened to Dad, he had taken an over-the-counter medication. I don't remember if it was for muscle cramp or a cold, but we even had called the neurologist and she said, keep him comfortable. It's fine if he takes this medication. And then translated, that means you're going to have a very interesting afternoon. He saw neighbors from Oregon driving past the house. He saw a woman nursing a baby in our patio in the backyard. It was wild. Trying to keep him in the house was really challenging. And then those hallucinations continued and became more frequent as the disease progressed. And the neighbors found him out by the highway and brought him home. It was effort to kind of keep him safe. He wanted to go dismantle the lawnmower. He wanted to work with saws in his shop, and we were really afraid for him to injure himself. But my mom's attitude was, this is how he lived before he got sick. And if it's what kills him, he would rather die doing what he loved to do, even if he didn't know what he was doing. So yeah, it's scary.
Yeah, it is.
Dr. Miller, Denise brings up the REM sleep behavior disorder, and certainly that came out in the Spark film in terms of Robin Williams suffering from some sleep issues. How common is REM sleep behavior disorder and Lewy body dementia?
Yeah, it's still Robin is under active study, but I would say somewhere between 60 and 80% of people with Parkinson's had either, like you've heard, a prodrome before the Parkinson's REM behavior, or it developed soon after the diagnosis. So it's really common. And I think, thinking a few years down the line, if we had a great prevention for Parkinson's and we knew that it was beginning, and the sleep disorder is really the beginning of Lewy body disease, that we would be able to intervene before any of these other profound problems occurred. So I think it may turn out to be a fortunate feature of the illness that we get sleep changes that tell us that Parkinson's is coming.
One of the attendees asked, getting back to this prodromal symptom aspect, and you mentioned early on, Dr. Miller, that anxiety, depression can be early symptoms before even anything else appears. REM sleep behavior disorder can be that way. She mentioned that her mother had had hallucinations as the primary symptom. I would imagine that having a psychiatric symptom like that would be very confusing for neurologists. Back to your bucket about movement symptoms versus psychiatric symptoms, it would be very difficult to diagnose in that case.
I think that there's some features, and Denise described them really beautifully, of these hallucinations that should really make you think about Lewy body. They tend to be formed, little children, little people, very vivid scenes, sometimes, very disturbing to the person, but sometimes they actually sit back and enjoy it. And so I think hearing that anyone later in life is getting visual hallucinations, we want our physicians, whether they're in primary care, in the emergency room, or in neurology and psychiatry, to say, this is something more than schizophrenia, which of course doesn't happen later in life. So I think the problem is education. I really think that that's where this breaks down.
Yeah, and to that extent, what is being done about educating physicians?
I think we're just beginning, and I think part of the problem for some of this is primary care doctors don't get reimbursed for spending a lot of time with families and thinking through symptoms like this. The state centers, Alzheimer's centers across California, one example, are beginning to work in a program called the ECHO program, which is opening up time for primary care physicians and probably eventually families to actually consult experts. So I think the more and more we get palpable evidence that we have therapies for these disorders, the more I think the families will demand that they get better diagnosis and care and treatment. And so I think this is coming. And I think the work that you all do in advocating is going to change the way this is dealt with. And the suffering that families go through with Lewy body is about as high as any illness that I have ever worked with.
Diane, one of the symptoms of Lewy body dementia is hallucinations and delusions. Could you speak a little bit about your experience with Gary and delusions?
Yes. He had a sundowning, is what we called it, every afternoon that would go on for hours and hours. He was a pilot for a commercial airline, and the first symptoms that we were really aware of happened about 5 years after he retired. So at age 5, he's already showing some terrible signs. And one of the every afternoon was he kept reaching out and touching with his fingers, trying to make his eyes focus to what he saw as the cockpit of the airplane. And unfortunately, he knew he wasn't seeing it properly, and he couldn't tell what his altitude was. And he kept trying to make his eyes focus on that dial. And then he couldn't remember where he was going. And he was terrified that he was about to cause an airplane with 200 passengers and himself to crash because he couldn't see well, he couldn't land an airplane in that condition. So when I would see him doing this, once I figured out what he was doing, I managed to tell him, it's okay. The co-pilot has landed your airplane, and now we're sitting here at crew rest. And he would be so relieved. Thank you for telling us. I'm so glad that we're here. Now, let's get this thing on the ground, and it would start all over again.
Oh.
So I would let him know that we're on the ground, we're crew rest, we get him all, and then have to change the whole focus of whatever we were doing, change the subject really quickly before he gets back into the problem. it was difficult.
Terrifying, yeah.
And the other part of it was later on, even as caregivers, we became his jailers. He was also an Air Force pilot for 10 years. And so military training taught him what to do if they were captured. And so we were his captors for quite some time.
Terrifying. One of the other, I think, very challenging symptoms of Lewy body dementia that we hear a lot about in our local support group is fluctuating cognition, where the person can seem totally fine 1 minute and not fine the next minute, or it may vary on the basis of an hour or a day. Denise, I'm wondering if your father exhibited this symptom, and if you could give an example of it.
I have such a good example. I came out from my bedroom one morning, and the caregivers had got Dad dressed. He was sitting on the sofa in the living room, and his shirt was tucked into his pants, and it was really bunchy. And I knew by the afternoon that was going to be irritating, and he was going to be, less cooperative and upset. So I told him, stand up, Dad, and I'll help you smooth out your shirt. You'll be more comfortable. And he stood up. We did it, undid his belt, got him all set. No butt hit the sofa again. Then Mom came around the corner and said, breakfast is ready. So I said, okay, Dad, we'll stand up and we'll go eat some breakfast. And he had no idea. It was like I was speaking Martian. Any suggestions that I would make to use the arm of the sofa or his walker or something to help brace himself, lever himself out of the chair, he was just completely confused. And, after 5 minutes of this, I was at my wit's end, and they're not allowed to eat in the living room. It's a new carpeting. I thought about Dad, and he's always about his food. And I just said, Dad, go eat. And he stood up and he went in the kitchen because he wasn't thinking about what I was trying to say. But it's just that fast, English, Martian, English in, 10, 15 minutes time. Crazy.
Yeah.
Dr. Miller, what's the neurochemical or protein-based explanation for fluctuating cognition? How can this occur?
This is acetylcholine, I believe.
Oh.
And I think there is what we call a cholinergic deficit in people with Parkinson's, sometimes before they ever develop symptoms. So when we measure this, we don't do it mostly with PET scans, but we can. There's a profound deficit in acetylcholine, and that's the alerting chemical. It's part of our reticular activating system that says, wake up, attend, focus, and when someone has symptoms like this, I always treat them with a cholinesterase inhibitor. It boosts acetylcholine. The FDA-approved drug is a patch, rivastigmine patch, but I think there are other ways to do this. But I think this is something, again, that we can really manage and help people with. We don't get rid of the deficit, but we can biochemically alleviate some of the loss of attentional capability.
Denise, back to you again. I'm wondering, what were some helpful things to you as a caregiver, helpful resources, helpful information?
Yeah, my parents were, well, older. Dad was 80 something when he was diagnosed with Parkinson's, and they had a computer, but they mostly just used it for email. So I would look up information as mom complained about dad's challenges, or early on if he complained, and try to find some information about preventing falls and preventing wandering and whatever. And so when a friend recommended a caregiver support group and I had sought out a Parkinson's support group, I just found information with other people and learning how they cope with the same challenges to be immensely helpful.
Great. As the support group leader,
Yes.
we say that's great.
Yes. My second or third support group leader.
And Diane, how about for you? What things did you find most helpful as a caregiver? What resource?
Well, I also went to whatever I could find to help try to make him more comfortable. So I went to Parkinson's classes and support group. I went to Alzheimer's support group. I took a week-long class with Family Care Alliance, which is where I met Christine. And then just quite by accident, as I was getting a monitor to wear, when I wasn't there, the installer of the unit mentioned Robin Riddle's support group.
Wow.
And I said, oh, they actually are Parkinson's Plus. That's exactly what I need. And that has been so helpful to me. And it's why 10 years later, I'm still helping the group, because they helped me. So, I mean, complete with the signing up for the brain autopsy and a total body autopsy, which I had sisters-in-law that did not really think that I was helping their brother enough, that I just the thought of him not being in a care situation, not living at home, subjected a lot of problem. And to be able to tell them this is what he had, and the rest of his body was totally in good shape, in wonderful shape, but it is the disease, and it fluctuated. And yes, he would do Showtime anytime we're around, which they didn't bother coming very much after that.
It's interesting that both Denise and Diane, you both donated your family member's brain. Diane donated Gary's brain, and Denise donated her father, Harry's brain. Denise, could you say just a little bit about brain donation?
About why we donated?
Yeah, why you donated, what was the value for you?
Yeah, Dad mentioned to me one time that he hoped that there would be a cure for Parkinson's before that got him. And after I joined the support group and learned about brain donation, I just thought, well, you can't contribute to the cure if you're not part of the research. So we donated his brain without asking him, but he's part of the research. So, yeah.
And I'd like to ask one last question to Dr. Miller, since you're the optimist on our panel. Could you say what is happening just generally in the area of research, and why you are so optimistic?
Well, I think that we have a community now that's very organized around cures. I think this was unbelievably important, is to start setting lofty goals. I think the research funding, we are in a very good space. Over the last 5 years, the Aging Institute went from less than $1 billion to $3.5 billion a year. This is extraordinary. And the new administration has said they're going to get us even more funding. So that's one thing. I think understanding this in a lot of detail. And also, I think systematic efforts, not so much in the pharmaceutical companies yet, but in academic laboratories to figure out ways of preventing bad proteins from aggregating, from decreasing the inflammation that happens when the proteins aggregate, from telling the cell to figure out better ways of clearing these bad proteins. This is, I think, a common thread of all degenerative diseases. As we get older, we're not as good at getting rid of the garbage in the cell. And so there are brilliant investigators like Anna Maria Cuervo at Albert Einstein University who are designing drugs that will help the cell get rid of this bad protein alpha-synuclein. So I think our diagnostic abilities are improving. It could be a lot better with Parkinson's. We don't have those great blood biomarkers yet that we do with Alzheimer's, but they're coming. So I think early diagnosis, early intervention, smarter drugs. I think this is a very optimistic picture for the future. It really is.
That's wonderful. That's such good news. Christina, we're at the end of our time, so I'll turn things back over to you.
Thank you. And thank you so much to Robin and Diane and Denise and Dr. Miller. Thank you for the Lewy Body Dementia Association for use of the film today. We will send out a recording of this panel discussion as well as a resource list to everybody in the following days, so keep an eye out for that. For more information on Family Caregiver Alliance and future events, please visit us at caregiver.org. But thank you all for joining us today, and we hope the film and this discussion has shed a little bit more light on this disease. And again, really appreciate the time of our panelists and all of you for joining us. And thank you, and have a good rest of your day.
Thank you. Bye.
Bye-bye. Bye-bye.